very important to understand what's happening with breast cancer. That means more and more people are being diagnosed. You are likely to know somebody that has had breast cancer. We currently quote about 1 in 8, 1 in 7 women will have a diagnosis of breast cancer in their lifetime, about 1 in 1,000 men. So it does affect men, but obviously not in as great numbers as it does women. But the other interesting thing about this graph, and this graph is actually quite old now, as you can see, it ends in 2009, is that the black line shows people dying from breast cancer. That trajectory is downwards. So despite more and more people getting diagnosed with it, fewer and fewer people are dying of breast cancer. And why, when I talk to a Black audience, because our outcomes are not as good. So our mortality, or the number of women dying from breast cancer that are Black, is actually up to 40% more than white women. So I think it's actually really important that we as a people and as a community understand about our breast cancer risk, understand how we can reduce that risk, and understand that if we do get diagnosed, if we're unfortunate enough to be diagnosed with breast cancer, that it's actually a very treatable, survivable disease, but we need to do more work to understand that why we as Black people don't do as well. So breast cancer is essentially the abnormal growth of cells within the breast. And there are two types. There's one that come from the ducts and one that come from the lobules. And by far, the most commonest type is the ones that come from the ducts. And there are several risk factors for breast cancer. The breast density actually decreases as you get older. Family history. So there are some genetic predisposition to breast cancer increasing with time. Ionizing radiation, we know, and the commonest reason someone might get ionizing radiation, which again is not common, is if you had something like a leukemia, increase your risk of developing a cancer in the future. And so you may need screening, or you may need diagnostic surgery to reduce your risk in that from that perspective. Reduce estrogen. So it's about estrogen and the load of estrogen over your lifetime. So things that we can modify, and this is harder and harder to shift weight and obesity, but again, with a lot of these things, and it is worse in areas such as London. And the purpose of screening is to pick up any of these either precancerous changes or cancer over the age of 74. And essentially you get an invitation and you have to contact them to book your appointment to 74. You can request to be screened. You essentially have what is a mammogram, and that does involve compressing the breast, and you have it in 2 views, so they can look for any changes in the breast. The majority, and the vast majority of women, so 90 to 97%, it's normal. Nothing further needs to be done. About 3 to 10% get called back for further investigation. But of those, only 1% will then go on to actually have something that needs treating. So, like I said, the vast majority will come through the symptomatic pathway. So this is just an example of my area and how screening just completely tailed off during COVID. It's starting to tick up again, but I think what's really important is that it's changed the way that they run it. You now need to request your appointment. So obviously COVID-19 did affect things quite significantly, but I think we say that we're sort of past it, but we're trying to get back to business as usual. So I would really strongly encourage people to engage with the screening. And again, we showed that there's lots of sort of barriers and facilitators to why women of an ethnic background would engage or not engage. Things like this, where you have targeted health interventions, where you have professionals that look like you talking to you about the risk of disease, we know can be quite effective in improving outcomes. But I think that the take-home message really here is that we're not very good at taking up our screening, that it's something that we need to instigate. So you'll get an invitation, but you need to book the appointment, and that if you can get screened, you know, if it by and large will pick up something in the early stages, so therefore your outcomes are better. So going back to the symptomatic route, so this is the way that a lot of the women are going to come to us, okay? And particularly in Black women, and the reason for that is because we tend to get it younger, so we're not within the screening age, is that you really do need to know what's normal for you. So you need to know your breasts. And so this is a short video just to go through that. I'm just going to play it now.
So the first thing to do is realise that breasts are lumpy bumpy and they're very individual to each person. First thing to do is relax. It's actually not that hard to be breast aware. Most of our patients who come and see us in the clinic have found a breast cancer by accident. It's not that subtle, it's easier than you think. You will notice if there are any changes to your breast. Best thing to do is to do this when you're in the shower or the bath. And if you're thinking about grabbing that sponge to wash your breasts, just don't. Get rid of the sponge. Just lather up your hands and use your bare hands and wash those breasts and under your arms. Take a look in the mirror and have a look at how they look. Raise your arms in the air, turn side to side, and just get to know how normal looks for you. Don't go looking for lumps. Now, this might sound strange, but normal breast tissue is very lumpy. We have lots of fat lobules, we have milk lobules, we have ductal tissue, we have supportive tissue, we have lymph nodes, and all of these feel like little lumps and bumps in your breasts, and that's completely normal. Now, some women have very fatty breasts, some women have very dense glandular tissue. Again, very normal. So what you need to be looking for are changes. And don't panic. You notice something, just don't panic, okay? Have a feel and monitor that. So below is a pie chart. This shows you the amount of patients we have in the clinic. The little blue area, that's the amount of patients that actually come to us with actual cancer.
So I think, the take-home message there is that let's go back again. The take-home message is you just need to be kind of like breast aware. You need to be able to know what's normal for you, and therefore you'll know if something changes, and that's the time to present. Go and see your general practitioner, and they will refer you up to the Breast Institute, your local breast clinic, for further analysis. And the kind of things that we're looking for: changes in skin color, skin texture, dimpling. It's not always a lump. So lump is obviously the commonest, but you might see that your nipples have changed. They've become pulled in. You get a bloody discharge from your nipple. These are all things which may suggest that there might be an underlying cancer. Like I've said, the vast majority of time, it is not a cancer. But if you do see changes in the breast, it is best to get it checked out, so that if it is a cancer, we can pick it up and we can get on, we can deal with it. Because again, I emphasize, we are getting very, very good at treating breast cancer, but we can only be good at it if we present in a timely fashion and if we engage with the treatments in a timely fashion. So let's just go through some of the myths. And I think a lot of people don't think that breast cancer kind of applies to us. It's not a black disease, it's a white disease. And I think part of that is because of all the sort of like the literature, the marketing, it's very sort of white orienting. And I think that's changing now. I run an annual conference and we have a lot of stakeholders. So we have a lot of healthcare professionals, we have a lot of charities who do a lot of that sort of marketing, that do a lot of the sort of the publicity pushes. And they are now cognizant of the fact that if you don't have different types of people in that literature, in those sort of advertisements and things, that you switch off the people that are not represented. So it is a disease that affects all of us, okay? And Black people do get it worse. So I think it's really important that we understand what the signs and the symptoms are, and also where to go for help. Yes, the majority of women that get it are older, but again, specific to Black women, we tend to get it younger. So it's really important to know how to examine your breast and for us to engage in the screening. So this just illustrates, and this is old data now, but this kind of illustrates it. If you look at the data on who is getting breast cancer and at what ages they're getting breast cancer, you will see that the vast majority of white women get it in their early 60s, mid 60s. Black women, 50. So we're just on that cusp of screening, and the range is between 40 women that pick up their breast cancer through examination and not through screening. But similarly, there will be some that come through screening. So it's really important to engage with our other counterparts, and these are white and Asian. You'll see even screen detected, okay, again, Black women more likely to get it at a higher grade. So I think it's really important for us to understand that Black women do get this disease at a higher. So why do we get a worse outcome? Well, we're not entirely being overweight, poor engagement with treatments and healthcare professionals, part of our culture, our beliefs, our religion, the biology of the cancer. We're not entirely sure. What is probably a combination of all of these things? And I think it's really important that we get information from credible people. So that's why it's really impressive to see so many people dialing in on a Saturday morning to hear this lecture, because actually, this is what I do on a day-to-day basis, okay? So getting information from credible sources is really important. And I think it is going to take a multi-pronged approach. At the community level, this is what I would consider a community intervention. We do health awareness events. So this was us at a Gambia Day, where we brought our stand with our leaflets. We brought our mannequin, which you can see in that the far right corner, where we taught people how to examine their breasts. This was us in a local, in a community centre attached to a local mosque. Similar, we brought things about screening, we brought the mannequins so we can teach people how to examine our breasts. And we do talks such as this to local groups. We talk about breast cancer in general, what we can do to reduce our risk, the types of treatments, the role of family history and genetics, and what kind of surgery you might expect. As I've mentioned already, I run an annual breast cancer awareness conference. It's called the Let's Talk About Black Women and Breast Cancer Conference. It is specific for Black women, in that it's about Black women. So it's not specifically for Black women, in that I want everybody who's got an interest in breast cancer care to attend. So we have members of the public, we've got people that have previously had breast cancer or are currently going through breast cancer. We have got charities that come, we have pharma, so we've got pharmaceutical companies that are developing these drugs. We've got the clinical trialists. So it's a whole milieu of all the people that are involved in breast cancer care, some of which will be Black, the vast majority are not, because they need to understand that there are different nuances in relation to Black women. So this conference is specifically to highlight that, so they can start to think about the way they deliver their services, the way charities deliver their care, and the way that research is conducted to encourage Black women to become part of research. And then there's other things that we do. So we do talks, we raise the awareness, obviously through things like this. I've been in a sort of exhibition at Francis Crick, which is like a big cancer research institute in London. We do podcasts. All of these things are trying to sort of raise awareness. And like I said, I do a lot of talks with charity, because at the end of the day, it's quite important that, if you are in the business of helping people that are going through cancer or trying to raise awareness about risk reduction strategies for cancer, then the marketing needs to appeal to a whole range of people. And I'm actually now, I've been coming up to 2 years now, a trustee at Breast Cancer Now, which is one of the major breast cancer charities in the country, because I think it's actually really important that we see ourselves in these spaces so that we can try and influence change and policy. And obviously we've talked about I've laboured at large about my conference, and I really hope that some of you will be attending. We have the main event down in London, and hopefully they can share the links with us after this call. There's the main events down in London, but we're having watch parties around the country, and Khan is helping me sponsor one of these in Manchester. And so if you can't get down to London, you may find that there's some local watch parties near to you that you can attend instead. Even today, as we're speaking, my father is in Nigeria right now doing a health awareness event. He's coming up to 75, and he's been a doctor now for a good 50 years. So in commemoration of that, he's actually gone back to his village in Nigeria, and he's doing a health awareness event there. So this was me doing some consultations with women to talk specifically about breast health and do breast examinations. And this was the team. So this is pre-COVID, and that's the tall chap to the right is actually my brother. So he's an A&E consultant. And this is one of the things that I labour a lot. Research. One of the reasons that we don't know that much about how this disease affects Black women, and also how treatments affect the disease in Black women, is because we are not represented in clinical trials. And I say Black women, but also Black men. So one of my sort of things is that any Black person that's got a disease, we should be grabbing them and we should be asking them if they wouldn't mind getting involved in a research project, because we're not that populous. We're 3% of the population. And so in order for us to get represented, a lot of us have to show up and need to get involved. So research is really, really important. And I really try to get things like Cancer Research UK, etc., to come to my conference so that people can have that one-to-one discussion with them, can try to understand what it means to be involved in research projects and what it will take out of them to be part of it. It may not affect your trajectory right now with your disease, but it could affect the next generation. And so it's really important that we start having those open conversations about what it would mean to be involved in research. So I'm going to stop there. That was a bit of a whistle-stop tour, but I'm going to stop there just to give people the opportunity to be able to ask questions.
Well done, Miss Georgette Oni. Thank you very much. You have taken a very broad subject matter and compressed it into minutes. That's simply fantastic. A background to what you summed it up, saying that this is something that affects both males and females. It affects females a lot more. Interestingly, Black women are 40 times more likely than
40%. So
40%, sorry, more likely than white women to come to harm following having this condition of breast cancer.
So dying. I mean, I think that's what we need to emphasize. This is a treatable disease, that the majority of people are surviving,
very
but
critical.
Black women not as much. So I think we need
so
to...
what are those barriers that has cost us in the Black and ethnic minority not to be able to get us a better outcome? Why do 40% more of us have to die from a treatable disease? And we've talked about our religious beliefs, we've talked about the barriers to accessing screening. Some of them are our own inertia, some of them are religious. Some people, you just don't want to come or undress before someone else. There are the myths that a mammogram is so painful. It's not painful. It's not at all. It can be discomforting, but it's not painful. And a lot more out there. And just to throw something in before we start taking the questions, I think they're coming in now. I had a patient, obstetrics and gynecology. Somehow the gynecology part, we pick up some of the patients as well for your side. This patient was saved by her husband. And how did that happen? He suddenly noticed one night that the breast was discharging a strange fluid when he sucked on it. And that was how he saved his wife.
So this is not uncommon, actually. So yes, oftentimes a partner will pick up a lump, and that's not uncommon.
Uncommon.
Yeah.
But you see, sometimes why I'm bringing this here is that in our own social cultural dynamics, people don't discuss. People even turn off the lights to have sexual intercourse. Husbands, they don't even, and wives don't know how their own bodies look. And you are the first person positioned as a partner, as a husband or as a wife to detect what is wrong in the other person's body. So these are things we should break out of. There are social cultural norms we should come out of.
I completely agree. I think it's very important to know what is normal for you. And there isn't, someone's just put in about screening programs, but there is no screening program for men. The vast majority, the men come symptomatically because they just don't have, they've got breast tissue, but they don't have enough to be able to put into a mammogram. So again, it's self-exam. And yes, if you're not happy self-examining, get your partner to do it.
Exactly.
And it doesn't have to be every day. It can be once a month, but you just need to know what's normal for you. And just, be aware of changes and seek prompt medical advice if you find a change.
Excellent. So there are many, many questions here now. Let's go ahead and take them. The first one is saying, what are the potential side effects of breast cancer treatment and how can they be managed?
So there are a lot of treatments. I think the first thing to do is just take a step back and talk about breast cancer treatments, okay? So broadly speaking, there are 4 types of breast cancer treatments. There's surgery, and the vast majority of women will have surgery. There are tablets, and there is radiotherapy, and there are, historically they were called chemotherapies, but I've actually changed that now to what I call systemic or circulating treatments. These are treatments which basically go into your bloodstream and circulate around your body, of which chemotherapy is one of them. And the reason I say that is because increasingly there are a lot of new treatments coming onto the market, things that target your genetic predisposition, things that target receptors on the breast cancer. These are all systemic treatments. And so we are getting better and better at personalizing breast cancer treatments. So it very much is a discussion between you and your healthcare professional, what you're going to need, when you're going to need it, and how long you're going to need it for. So it depends on the modality, what, if any, side effect that you're going to have. So that is a whole sort of another hour of discussion about treatments and side effects. But the vast majority of people are going to have some sort of surgery and some sort of what I call systemic treatment, not necessarily chemotherapy. And I think what people panic about, there's 2 things patients ask me when I give them a diagnosis of breast cancer. The first is, am I going to need chemotherapy and lose my hair? And the second is, am I going to need a mastectomy? So the majority of women don't actually need chemotherapy. However, because Black women present at a higher grade, a higher stage, those are things that are more likely to push you into a group that then requires chemotherapy. So the earlier we can diagnose, is the least likely you're going to need chemotherapy. The second thing is not all chemotherapies are the same, and so not all are going to lead to hair loss. It's really going to depend on what you have and what you need it for. The second thing is about surgery. Again, 80% of women, 70% of women do not have a mastectomy. They have what we call a lumpectomy. So take out the cancer with normal breast tissue around it. That is called a lumpectomy. We try to preserve the breast. Again, this is only possible if it's a smaller cancer that's picked up early. So a lot of it is determined by how much disease you have when you get into the doctor's office. So the majority of women don't need chemotherapy, don't need to have a mastectomy, but usually that's because we've got it early.
Thank you very much for that. There's a question here. My mom was listening in and she has a question. She's saying that you said that there can be screening up to 74 years of age. After 74 years of age, what do you do? Do you go to your GP and ask for a screening? And if so, how often should you do that?
So really, when you're getting into that age, it's what we call self-requesting. So if you feel something and you're a bit worried about it, you can then request a mammogram, or you can go to the doctor and be examined to check. So I wouldn't recommend that you're having it sort of, like every year or what have you, because that's not what we recommend anyway. We recommend 3 yearly mammograms. But again, I would say you need to continue examining yourself. And if you pick something up, get in to see your medical professional sooner rather than later.
All right, thank you very much. Selina Medford is saying an amazing talk. Thank you very much for the presentation. And there is something here that is saying, how are men diagnosed? Is there a screening system for them? I think you answered that.
So no screening, self-exam.
All right.
And I think actually on that point, what's actually really important about men. So yes, they can get breast cancer. So I think probably one of the most famous ones that people know is Beyonce's dad had breast cancer. But you can pass on the breast cancer genes down the male side of the family. So it's actually quite important to know both sides of your family. It's not just, oh, my mum's sister had a breast cancer, what have you. You need to know what's going on the father's side as well, because the breast cancer gene can come down the father's side of the family.
Fantastic. Thank you, Dr. Oni, for clarifying that. Nusrat, I'm sure you're happy with that question. And then how do genes affect breast cancer risk? Can genetic testing help detect if those who think that they may have a breast cancer? Yeah.
So the first thing is you've got to know your family history, right? So you need to talk in families, and that's one thing we're not really good at. I mean, I'm coming from quite a medical family, and I go, okay, what did my aunt die of? Oh, something. We're not really sure. We don't really have those discussions about illnesses that people have and then succumb. So this is what we need to know about. We need to know what they had and when they died, and these are the things that can build up a risk picture for you as an individual in that family. So you need to know the family tree. And like I said, it's important to know both sides of the family. If you have a significant enough family history, and a lot of breast clinics now, if you think you've got a significant family history, you can get assessed as to whether it's strong enough that you need enhanced screening. And they'll risk you sort of low, moderate, high risk. And depending on where you are, you might have enhanced screening, which can range from having annual mammograms instead of 3 yearly, all the way up to having MRI scans. So it really, really depends on that first discussion about what is the family history. And the genes, just talking about the genes themselves, the commonest ones are BRCA1 and 2, okay? And these genes can increase your risk of breast cancer in your lifetime up to 80%. So it's quite significant. And it's not just breast, it can also affect your ovaries. So it can also give you ovarian cancer. So if you are a gene carrier, we have clinics dedicated to women that are gene carriers to talk to them about their risk reduction, which can sometimes involve having a double mastectomy or having your ovaries removed.
Fantastic. Then we have another question from ZG. Can I just request that if you could put your own name on your devices, the Zoom device, that would be great. But ZG is asking a community-based question directed at us, BAME, saying, great presentation, Dr. Oni. Concerning the research point, many Black people have a trust issue with medical profession and the professionals. Their experiences over the years have been one of disappointment. How can this trust issue be addressed to make them more comfortable, I think, with engaging with research?
Yeah, so I think, this platform is a great example of the fact there are lots of people that look like us that are delivering healthcare in this country. So we're part of that system, we're delivering healthcare, and we're delivering it in lots of different spaces, and that number is increasing, but there's a lot more Black people going to medical school, there's a lot more Black doctors within the system, and there's a lot more consultants who are of Black descent in the system. So I think that helps. And I think having those conversations and knowing that we are there to ensure that people get equal treatment, okay, so obviously we've got skin in the game, right? If I was, to develop a breast cancer, I want to know that I've got a similar outcome. So I think that this is what we can do. It's obviously going to be a step-by-step process. It's not going to be an overnight thing, but I think the more of us that are involved in the way that research programs are developed, the delivering of those research programs, healthcare, I think this will help to sort of bridge the gap. Look, and one of the things that I often sort of say is that, look, at the end of the day, we're only 3% of the population. You are going to, yes, that number that are involved in the medical profession increasing, but you're not always going to have someone who looks like you delivering your care. And I think that, as an individual, we all want to survive, right? We want to get the best treatment that we can. And so engaging, that's all we can do, right? We can engage. And then if you get less than satisfactory outcomes, you can ask for second opinions. And you can get a second opinion anywhere in the country. It does not have to be local to you. So, you can do research and you can say, okay, you know what, I want to go to that unit and I want to get a second opinion from that unit. There are things that can be done, but it is very difficult. And, these are things that have been entrenched over centuries, decades, and we're trying, slowly, softly to undo the wrongs. And there are a lot of allies in this field. Like I said, my conference, the majority of people that come and sponsor, they are not Black. There is no reason for them to be there, but they're there because they realize that there is a big, stark inequality and they want to work to try and reverse that.
Thank you very much. And just to buttress your point, that's why we are having these kind of programs, and that's why we have to thank Khan and Kachip. I mean, the professionals who come here are actually excellent professionals. They look like you. They talk like you, they're one of you, and you can actually get our contacts as well and informally ask for second opinions. I mean, I've had to do that for people who send me emails or send me messages and say, I saw you on Khan Network and I just went to my doctor. My doctor said A, B, C, D, X, Y, Z. What do you think? So these are the things that you can utilize these exposure and engagements for. There's someone here who is asking that, what is there a danger of overscreening when you expose women to too much radiations on their body and you are looking for these cancers? Or what is the percentage of radiation that the body is exposed to as a result of screening? And this is from ZG again. ZG, Can you please label your device, your full name? Go on.
So, this is a common question. And what I say to people about this is, if I offered you a free flight to New York every 3 years, would you take it or would you go? And the audience, everyone puts their hand up. And I say to them, well, actually, you get more radiation from that free flight to New York every 3 years than you would from having a mammogram. So none of us have any problem with getting on a plane and going on holiday, right? Yeah.
Simple. Holiday versus your mammogram. Choose you this day. Are there some specific bras that predispose women to breast cancer?
No.
Or are there some specific clothes that will predispose men to breast cancer?
No.
Okay. Can the doctor tell us why, if Black people are likely to get breast cancer earlier, what conversations are taking place at the NHS level to encourage Black women to engage with breast awareness or breast cancer awareness? Why is the advice focused on those over 50?
So the screening program, it focuses on those over 50. Why? Because, we go back to one of the graphs I showed earlier, the majority of women get their breast cancer over the age of 50. And so therefore, if you can pick it up earlier, we know that the outcomes are better. So that's the reason, right? And with a lot of screening programs, you've got to balance a lot of things. You've got to balance the cost against the risk, against the outcomes, and what the intervention is, that's going to produce those outcomes. And so that's the reason why the screening program is set up the way that it is. It's cost effective in that format. However, the reason that we do things like this is so that specific demographics understand what their risk is. So therefore, so that's why I labour the point. At the end of the day, they're not going to come up with a screening program, well, not yet anyway, that is specific to Black women. And so therefore, we need to be part of our own, destiny, essentially. And so that's why we need to know what's normal for us, and we need to examine ourselves, and we need to know how and when to present. And so that's the purpose of things like this, is so that we can raise the awareness and the education level amongst ourselves, so that we know what we're asking for and why we're asking for it.
We need to help us. We need to take our destinies in our hands. Summary. The questions from Maxine and June Green, they are similar. So I'm going to take them together. They're asking about a lump under the armpits and could pain behind the nipple and no palpable lumps be an indicator or a sign that somebody has breast cancer?
So these are great questions. So lump in the armpit, there's lots of things that can cause a lump in the armpit. But if you have a persistent lump in the armpit, then yes, it should get checked out. Why? Because again, there are loads of reasons why you can get enlarged lymph nodes, right? So that's like glands. And we have lymph nodes all over our body. So they're in the neck, they're in the armpit, they're in the groin, they're inside you, they're in your tummy, they're within the breast. There are lymph nodes everywhere. They're behind your knee. There's lymph nodes everywhere. They're by your elbow. And so a raised lymph node in the armpit can sometimes be, it's not often, but it can sometimes indicate that there is something going on in the breast. So it could be a cancer, it could be an infection. Again, like I said, there's lots of reasons why you should have an enlarged lymph node. So again, I would get that checked out if it's persistent.
Yes, and just, go on.
No, I was going to address the pain. So the vast majority of women who have breast pain do not have a cancer. Yeah. So we often say that cancers are painless. Okay. But nevertheless, if you have persistent pain, you can go to the doctor and they can examine you, and they can then make a decision as to whether or not you need to go to a breast unit for further investigation. If you are of screening age and you have not had a screening mammogram in the last 3 years, then I would definitely recommend that you call up and you get that done. But it's going to be on a case by case basis whether or not they'd want to send you up for further investigation at breast unit. We get a lot of breast pain that come into the breast unit. And like I said, in our unit, for every 100 patients we see, only 7 have got a cancer. We see a lot of breast pain. And so we've actually, in my region, in Nottingham, we've actually set up a community breast pain clinic. So patients can actually go in the community. They don't have to come up to the hospital. They go in the community. It's actually at our local shopping centre, and can be examined there. And then they can make a determination as to whether or not you need to come up to the hospital for further investigation.
Excellent. And just to buttress what you said, people should consider those things you call lymph nodes, like they're the police, like the policemen and women in our bodies, sort of. And their task is to pick up the bad guys and consider the bad guys like germs, infection, cancers. So anywhere they find bad guys, they actually grab them and they swell up. So it's good to go and get it checked if you find any swelling under the armpit or wherever you find it. Selena Medford wants to find out what your views are on holistic approach, plant-based food, etc., to managing breast cancer.
So I'm a scientist. I base things on research and data. So we don't have any clear steer on that in terms of the research literature. If we did, then that's what we would be advising patients. And so I think that these are areas in which, there is gathering interest in how sort of food, nutrition, exercise, how all of these things influence outcomes of diseases. They're not just breast cancer, diseases across the spectrum. And so I think that increasingly, as we are starting to look at holistically about the way that we live our lives, these sorts of research studies are going to kind of come to the fore, and we're going to get sort of a clearer picture on it, I think, in the fullness of time. But at this moment, there isn't sort of any sort of big body of evidence for it.
Okay, excellent. And then sorry, I'm just trying to get this up. Okay.
I see someone said, is there a natural way of reversing the condition? And the answer to that is no. And this is one of the things that actually, this is the sort of thing that scares me the most, is I see someone in clinic, I tell them that they've got a breast cancer, I explain the treatments that they need, and then they disappear. And then the next time I see them might be months or the following year, and that cancer, when I initially saw them, it was curable. And then the next time I see them, it's spread to other parts of the body, which now makes it incurable. So this is something that does worry me, is when patients disappear, they don't start treatments and they disappear, and then by the time they come back, it's too far gone.
Yeah, that's true. And someone here is just thanking you for an insightful presentation, Iyabo Fasheun, and is saying a good point that we should participate in research. It's been highlighted severally on this programs and platform, and I think it's sinking in. Selena is asking again that she has a family history, dad leukemia, brother prostate cancer, detected early, cancer-free. So is it possible it will come down to my genes and that also of my young adult son?
Yes. So I think what we know right now is that a strong family history of breast cancer, okay, so mothers, sisters, aunts, and then pancreas, prostate, and ovary. So ovarian and breast are by far the biggest, and then prostate and pancreas. So our genes are really, they're very important things, right? So that they determine a lot of things, and we don't fully understand everything about genes as yet. But there are increasing, there are lots of kind of like what I call over-the-counter type genetic tests that you can do, and they'll tell you, oh, this is your risk of this, and you could have this and that and the other. But actually, what that means in terms of translating it through to disease actually happening to you, we don't have a handle on that. And a lot of these things are commercial, so you'll just pay for them, and then they'll spew out a lot of information, and then it's like, well, what do you do with that information, right? So I think in terms of things that we know we can do something about, that's going to be breast, ovary, prostate, pancreas. So we need to know family history of those so that we can calculate a risk for you getting a breast cancer. And sometimes if you've got a very strong family history of lots of other things, you can then go to a team called clinical geneticists, and they can then look at a different sort of panel, and they can sort of discuss with you then what your risk is and what screening programs might be available to you as a result of that. Because there's things like, bowel cancers and stuff like that they all can, there are other genes which play into those things. So it's not just for breast. I think we just need to know what's going on in our families, in our extended families as well. We need to know what's going on, because that's how we as an individual can then judge risk.
Yeah, that's true. Somebody wants to find out if there is a vaccine against breast cancer, just like there is one new one now against cervical cancer.
No, there's not. So the vaccination for cervical cancer is targeting specifically not that you don't get a virus, which we know causes the cervical cancer, right? So you have it as a school, I think it's like 12 or 13. Before then, you get the vaccination then. And the aim is that it will then eradicate cervical cancer, like in the next generation, because it's caused majoritively by a virus. It's not the same with breast cancer.
Okay. And then somebody wants to find out, would regular sucking of breasts reduce the risk of breast cancer? I mean, sucking by partners are not allowed.
No. So it's related. So it's related to breastfeeding. So we know that when you breastfeed, the amount of estrogen circulating is actually reduced. So it's all to do about estrogen exposure. So breastfeeding, pregnancy, late starting your periods, early menopause, these all reduce the amount of estrogen that's in your system cumulatively over your lifetime. So no, I wouldn't sort of encourage your partner to go out there sucking your breast all the time, unless that's something you want.
Except that's something you want, but however,
it's not medicinal.
Yeah, but however, in terms of picking up abnormalities,
examination, so it's not necessarily sucking. It's the examination. It's not, it's the examination is what's important. So
picking
checking for lumps.
Abnormalities.
Yeah.
And then someone is talking about saying that all human beings, over 99.9%, are the same. What is it about our ethnicity that increases our risk of certain cancers? Is it epigenetics, or is it nurture? Or is it simply our survivability and late detection? What exactly is it? Exactly.
We don't know. And so that's what I'm saying. We have to get involved in research. We need to show up, because nobody knows exactly what it is. We know that we're more likely to get the disease younger. We know that we're more likely to get a type of breast cancer called triple negative breast cancer, but we don't know why. And so until we get involved, in research, and research does not always mean sticking a drug in. Sometimes it can literally mean, okay, you're going to have this diet and this exercise, and we're going to compare it to somebody else that doesn't have this diet and exercise, and we're going to see what the outcome is, or it might mean, okay, we're going to take one blood test from you, and that's all we need. And that's you done, so there's lots of types of research projects. It might even just be, we want you to fill in a questionnaire. We just want you to tick some boxes and fill in a questionnaire. So there's a big kind of variety or variation in what being involved in research means. I think people sort of almost like lab rats. You're sort of strapped down to a table and they're extracting things from you. But it's not, there's lots of different types of research projects, and some of them involve very little, of our time, effort, or body tissue.
Yeah, and just to buttress that, some of it could just be the researchers just following you up because you are unique. For instance, I've never had chicken pox, and each time they give me the varicella injection, it just doesn't show up like I've been given for many, many years. And they stopped repeating it, and they said they just want to follow me up because that's really strange and unique. So sometimes they don't have to really
do anything. They just they just want to sort of have a chat with you every few months. Or
as Black people, we are very suspicious as well,
and with great reason. I mean, there's been some.
It's rightly so. Rightly so. We've had the bottom part of the stick in terms of some of these things. So,
but what people then don't realize is, as a result of those things, the ethics framework, the legality around it has tightened up so much to not allow it to happen again, right? So, there's real sort of constraints and sort of boundaries by which you're allowed to conduct research. And so, it is specifically so that those sorts of things cannot happen again.
You and I know that, and that's why we need to reassure our population group now and tell them it's a bit different now. Are there natural ways of reversing this condition?
Yeah, we covered that. There isn't.
And you mentioned, doctor, that obesity can increase the risk of breast cancer. Is there any information around this in terms of the level of risk or how much overweight one could be? Do you know whether this is a global issue? Because many of our people are actually overweight.
Yeah, so we are, but it's not just us. I mean, it's a global pandemic, obesity. We go by BMI. That's the best thing we have. And I know that there's lots of debates about BMI and how relevant it is or not relevant. But what we have at the moment, the baseline we have at the moment, is BMI. And having a normal weight, so in the normal range of BMI, reduces your risk, not just of breast cancer, lots of things. So cardiovascular disease, so heart attacks, strokes, diabetes. We're not just, these diseases are not in isolation. It benefits you across the board. Anybody that's lost a stone or 80, stone and a half in weight, they know they feel better. They can move better. They can breathe better. So, it benefits you across the board, not just in reducing your cancer risk. So I think, we need to think about the way that we're preparing foods. We're doing lots of things with oils and frying and all this sort of stuff. We need to really think about, are there ways that we can have the same sorts of foods that we like, but reduce that kind of like calorific intake in the way that it's produced.
And even the quantity, are there ways we can sort of cut down?
Portion control.
Control.
What the sort of proportions of what we're eating. So reduce the carb, increase, the protein, the vegetables, the fruit. It's those sorts of things. And actually, one of the talks that I have quite frequently on my conference is from a nutritionist. They've actually put together culturally sensitive nutrition boards. So for what's kinds of foods that different cultures like eating, what's the good ones and what's the not so good ones. So I think we just need to start taking ownership in that respect of the bit that we can do, which is around diet and exercise.
Okay. And then Maxine wants to know if anything, if the fact that Black people have lower white cell count has anything to do with us having more incidences of certain cancers or surviving.
Honestly, I'm not sure. We know that sometimes Black people do have a lower white cell count. It's just normal for them, and it may well play a role. Not sure. I mean, it might, but then it's like a lot of things I keep saying. Breast cancer is not in isolation, right? There are lots of diseases. So again, unless we do research, we're not going to know the answer, and we can't do research on this kind of area if Black people won't participate, because we are the ones that have that. So it is really about how we engage with research and who's doing the research. So we're talking about something that may benefit us. So somebody has to be motivated to do the research into something that's really only going to benefit a Black population, right? So, where are the Black researchers out there? So there are initiatives now to try and help and encourage Black people who have an interest in research to be able to deliver that, because a lot of the times you just don't have the network, the money, the facilities to be able to do things that you're interested in. And so, you know, there are big, you know, sort of organizations like Cancer Research UK, for instance, who have partnered up with Black researchers, it's called Black in Cancer, to try and help them to get the money, the facilities to be able to deliver the research that they think is pertinent to Black people.
Fantastic. Gemma and Selena are saying well done for your presentation. They think it's been very great. Iyabo is asking, can we have nutritionists and culturally relevant food?
Yeah, and we do. I just talked about that. So she's a nutritionist that comes and speaks at my conference. Pretty much she's done a talk every year. So the conference is in its 5th year, and I think she's done 4 out of 5. And she talks exactly about this, the effect of nutrition on health, and the importance of having cultural relevant information in relation to that.
Taslim is saying this has been very informative and thanking you. Can you just tell us, when is your next conference, Miss?
It's a week today, so please sign up. It's a week today. So
Where can people sign up? Can you give us?
Yeah. So hopefully we can put the flyer. I'm not really good. Oh, can I do that? Maybe I can.
You can do all things.
Let me see if I can do that. Right. So I'm going to put. So So the main event is in London, okay? And anybody that's, because I know that Cannes has big tentacles that stretch out everywhere. So anybody that's in London, come down to London. The benefit of coming to London is obviously you've got the lectures in the morning, but then in the afternoon we do workshops. So one of them is how to examine your breast. We teach people what to do. But then we also have workshops on breast cancer and breast cancer treatments. We also have a healthcare professional stream. So if you're someone who's involved in, providing care, we have a lecture series for healthcare professionals. And one of them is about kind of nutrition. There's one about sort of hair care during chemo and skin care. So there's quite a lot of interesting talks this year. It's a bit of a celebratory theme this year because we're 5 years old. We didn't think we were going to get to it, but we're 5 years old. So we actually have a drinks reception down in London. So come and join us for a little glass of wine, but just a little one because we know about the risk that's related to drinking and sort of canapes and stuff. So that's going to be really nice. But if you can't make it to London, we actually have watch parties around the country. So this basically gives you the opportunity to dial in for the morning lectures, like in a bit of a community feel. So a bit like the way we're doing it down in London. You're all in a room, we've got some drinks, we've got some refreshments. And so you can dial in for the morning lectures all together in your space. And then in the afternoon, some of the locations are doing workshops. So for instance, at the Manchester location, they'll be doing things like how to examine your breast. We've got one in Aberdeen, and they're going to be doing, again, how to examine your breast and bra fitting in the afternoon. We've also got Birmingham, so West Midlands, Wolverhampton. We've got Sheffield, and we've got Nottingham. So there are watch parties all around the country. If you can't make it to any of the watch parties, then you can join us virtually. And we've actually got people joining us from Ghana, from Nigeria, and South Africa. So we've got people that are joining from kind of all around the world, America, as well, virtually. But the watch parties are nice because you get to sort of sit in a room with like-minded people. You get to have some refreshments. You get to kind of like vibe off each other. You get to ask questions down to London. So I think the watch party is going to have like a nice feel about it. So yeah, come to London. But if you can't make London, there's a few other locations around the country, including Scotland, which is a first this year. We're really excited about Scotland.
Fantastic.
For people to attend.
Fantastic. I think we are costing to a close now, but before then, there's somebody who is asking you, talking about hair. Are relaxers linked to increased cancers in women of Afro-Caribbean origin?
So I think there is data emerging that these products are harmful to our health. So I think that there's going to be. I think what's gratifying to see actually that there has been a move generally as a culture to move away from straightening our hair with chemical relaxers. But there is some emerging data now that the chemical relaxers are harmful to our health in terms of breast cancer risk and uterine issues. So I think that I think we need to, as a culture, as a group, we need to be staying away, I think, from
We need to
chemical
love
waxes.
ourselves
Yeah.
the way we've been made, isn't it?
Yeah. You know what? People have personal choice, kind of like on what they want to look like, how they want to wear their hair. Hair is such an emotive thing for Black women. It's a really big deal, which is why I'm actually really excited that we're having a talk about hair and hair care this year at the conference.
Yeah.
But I think that we need to be informed about what those choices mean for our own health.
Well done. Somebody is asking about talking about BMI. My midrib is always big because I have a fibroid. Can this count and say I'm overweight?
Well, that's one for you, Larissa.
Well,
as the Omson gynae.
I would say that your BMI is your BMI. And if your midrib is broad, then we have to do something about that fibroid, because right now I'm getting worried that fibroid may be causing some compression issues. So yes, I would say you are overweight. Take out the fibroid, reduce your weight, reduce your BMI, see your gynecologist, someone like me, and then we can have an extensive talk about all that.
So a fibroid is not going to make you have a raised BMI. Would you agree, Larissa? No,
fibroid can make you have a raised BMI because at the time you get on the scale, your fibroid is going to add to that weight that you have. Sometimes we see 3 grams, we see 3 kg, we see that can affect your BMI. They can be huge, especially in us Afro-Caribbean women. So if you are strictly working with BMI, it can add to it. But if we are talking of internal fat deposits, then it may not necessarily add to that.
So that's the sort of thing where I would say you need to have a detailed personal consultation with your healthcare provider, because this is something that is specific to you and therefore not generalizable to everyone, because your fibroid, like Loretta has just said, could be so huge that that's what's contributing to it, whereas other people have got tiny fibroids which don't contribute to it at all.
Yeah,
would that be fair to say?
Everybody's special and unique, especially us women in our own ways. Somebody's asking if hair dye is a risk factor. Thank you, Carol.
Not that I'm aware of, no.
So many Black women with fibroids are given a hysterectomy. Why? When there is another way to treat it. I'll just quickly
we're going off topic, but
just to quickly say that everybody's fibroid is different. Everybody's fibroid is unique. However, just like Dr. Oni has pointed out, some of us Black women will present really late, and that time it's so huge that you just want to get the whole womb out. But you are special and unique. All cases are individualized and patients are managed holistically on their own merits.
Yeah.
So I think that we've had a really good run, and well done, Dr. Oni. There have been many comments that are just praising your excellence.
That's very nice.
So well done on that. I will at this point be handing over my co-host rights to, is it Darren or Sandra, so that they can go ahead and run the rest of the program. But just to say a big well done to you, Georgette. You've done a very good job.
Thank
you. Those
those
who took time out to attend, I think, Georgette, I think we should really thank them, because the problem I find in the Black and ethnic minority groups is that we don't engage. Once you tell us there's a party somewhere like Owambe, people will just turn up. But once it's something on gathering knowledge, information, something that will even prolong our lives, then we'll go to work and we take extra shifts. On that note, I'll hand over the mic.
Can I just say as well, I am absolutely amazed. 160 people right now on this call, and that is phenomenal for a Saturday morning. It's exactly brilliant. Brilliant.
We love them all. Thank you, everyone. Well done, Georgette.
Thank you so much. Really, really appreciate your time this morning, and to everyone that's attended, as the doctor said. So I'm Darren, and I work for Khan. So I'm just going to run a few of our thank yous from our sponsors. I'm just checking that I can do this. Sorry. Spray's on the call as well. Wonder if you can share my screen. Nope. I'll do it this way. I'm so sorry. So thank you for joining the session. The next session will be next Saturday, as usual, from 11 o'clock. So please join us then, and will be another very interesting topic. And there's a way of signing up. And I'll leave this screen on just for another couple of seconds if anyone wants to either take a screenshot or go onto the QR code. So same way as you came on today, I'll be able to get you on next time as well. So it'll be really lovely to see you then. And there's always a session on a Tuesday evening. The next one is this Tuesday coming up, and this is about nutrition and exercise. Somebody mentioned about diet and diet related things. We always have sessions on diet, really. So if you haven't seen one recently, you can go onto our YouTube page as well to kind of go back onto things. So this is really about diet and exercise and how to maximize energy whilst you're doing exercise. So we've got a physical instructor who does a little bit of a session as well afterwards. So we've got a dietitian and also our host who is also a nutritionist. And I'm sure many of you have seen the information about the Black History Month Gala. So the Caribbean African Health Network has got a gala on Saturday, the 28th of October. And this is really to celebrate towards the end of Black History Month. And it's also a fundraiser for one of our projects, which isn't funded by anything else really. So it's really kind of supporting Black people within the community to ensure they get the support that they need from our advocacy program as well. So tickets are still available. Feel free to buy an individual ticket or buy a table. If anyone's interested in buying a table and wants to talk through any other details, please do email us. I'll leave that screen on for a little bit longer as well if anyone wants to take the QR code. So that's on the 20th of October, and the food will be incredible. It's at Lancashire Cricket Club, which is one of the most prestigious locations in Manchester as well. And we've got fantastic hosts, and also it's going to be a great event to attend. There's also a video on YouTube about the last one, which just makes it look incredible. So I'm very excited about that. In terms of more of our work on supporting families and looking after our communities, there's a digital detox program on the 18th of October, and that's really, see if I can make my screen a bit smaller. Sorry. And that's looking at how to safeguard our children from addiction to social media. So again, that's online, and the QR code is just there. So it's on Zoom as well. So this is really for parents with children aged between 11 and 19. So we really want parents to attend this session alongside their children. And it's going to be hosted by Katrina Ali Adiat, who's the founder of the Strive and Prosper project. So please come along to that if you have concerns around this and have children in that age range as well. And we'll also talk about diabetes so frequently at Khan, and the fact that we have an increased risk of diabetes for several reasons, but also detection reasons as well. So please do stay on top of this, and also just learn as much as you can about this condition. And there's a QR code there as well for a bit more information, and also utilize the services that you have around you. Get seen by a doctor, get seen by your by health providers, and if you can, get screened. When we have our Khan events, we're usually able to screen for blood pressure and sometimes do blood sugar as well. So if you're at any of our events, please do ask for that, but please just get yourself seen externally. But the QR code is there as well for a bit more information. All of this is also on our website. We have legal drop-in sessions, which are also done in different languages when we need them for the advice sessions. But this next drop-in session is a general one on Thursday, the 26th of October in the evening. And we cover a lot of different topics, including access to access to benefits, but also some immigration topics, but also just advocacy stuff around rights of partners, for instance, and also home life. So if there's anything that you'd like to know, please attend our sessions. You'll be able to ask questions as well. So that's Thursday, the 26th of October at 6 p.m. Just a couple more things. We've also got a project on giving blood, so really focused on ethnically matched blood mattering. So it's really important that as much as possible, if you're able to, please sign up to donate blood. Really important for us in our community to be on the register to donate blood. If you can, and just to understand the issues around giving blood, and also knowing that if you've had certain conditions like malaria, that doesn't necessarily exclude you from giving blood. And this is the event that Dr. Georgette mentioned just now. This is a Manchester event, so 21st of October next week, from 9:30 to 3 at the Windrush Millennium Centre. This is about the Black women and breast cancer. And again, we'll be running through a lot of information about breast cancer and also doing a teach of examining one's own breast. So that's local to us here in Manchester at the Windrush Millennium Centre. And that's next Saturday. If you're able to attend that, it'll be really great to see you. And from our point of view, we just wanted to say a huge thank you to our sponsors as well. We've got the Enfield Caribbean Association, who support us all the time. We can't do this by ourselves. It's really great to have this organization. We've got RAFA International Development Agency, which continues to give us their support and ability to continue this work that we're doing. The Royal Assembly Redeemed Christian Church of God. And also we've got the Black Health Initiatives, which support us and help us carry on to bring these topics to you. So thank you so much for joining us today. And as I said, the details for next week's session will be coming to you in the next few days. Thank you so much for joining us today, and we'll see you next week. Thank you.
Welcome to our Caribbean and African Targeted Health Improvement Programme, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.